the prime time for benefit from hormone replacement therapy, namely estrogen, which is prior to the age of 60 and within 10 years of menopause. Some ADHD symptoms, a lot of that can improve with hormone replacement therapy because we know estrogen affects the brain. What's important to note is that women spend about 1/3 to 1/2 of their lives in this menopause time period. So it's a huge part of the lifespan.
Welcome to Medicine Redefined. I'm Dr. Altamash Raja.
And I'm Dr. Darsh Shah. Let's put the health back in healthcare.
If you're a high performer who wants a clear plan for longevity, performance, and staying active with fewer setbacks, I'm now seeing patients through my telemedicine practice refining health and performance. I'm opening a limited number of founding member spots at refininghealthrx.com. All right, let's jump in. Dr. Lauren Spivack, welcome to the show.
Thank you so much. Thanks for having me.
I'm super excited for this conversation, particularly because it happens every now and then where the media and everything that's kind of forefront in people's minds is a topic that we can talk about and actually put out there for people to get educated on, especially because there are people on both sides of the aisle from a political lens, and it can become really, really polarizing. Mm-hmm. So before we do that, before we talk about menopause and hormonal therapy or just hormone replacement therapy as people understand it, I want to get a little bit of a background on you. So what is it important about you that the learner should know, be aware of in terms of your background and how you got to where you are today?
Yeah, thanks. So a little bit of a circuitous path for me. So I am an OBGYN trained physician. And while I was doing my training, I decided, since I was more interested in gynecology and operating, that I wanted to actually complete a fellowship. So I did an additional fellowship called a Minimally Invasive GYN Surgery Fellowship, which was in Rochester, New York at the University of Rochester, which, unbeknownst to me, had a very big pelvic pain center. That was a large part of the training in terms of the minimally invasive GYN surgery, because a lot of what we were seeing was not only endometriosis, but all sorts of other things that are non-operative that cause pelvic pain. So I found myself doing fellowship with a large academic setting with a huge referral center they had a specific pelvic pain center. So at the time, I really didn't know a lot about how to treat pelvic pain. And it's sort of the dreaded chief complaint for gynecologists that people come in with very commonly, because we don't have enough time to treat it. And it can be very complex if you don't know how to treat it. So it was upon being there that I really got the tools to learn how to treat pelvic pain, and went from really disliking it to having a real passion for it, which happened to also coincide with my own struggles with chronic pain, back pain, and neck pain, where I really started to personally have this understanding of the impact of pain in one's life. So as I became really interested in pelvic pain and certainly developed the surgical skills from an endometriosis standpoint, I came back to New Jersey and really wanted to focus on pelvic pain. And in doing so, also began to see a lot of patients, menopausal patients, who were having pelvic pain from the standpoint of painful intercourse, vulvar pain, any number of things that overlapped with what I was seeing. And during OBGYN residency, there was a huge dearth of training on menopause, basically little to none. I had maybe one lecture on menopause. And so that we're trained very well in obstetrics, basic GYN. I had no training in menopause. So I came out as an attending and sort of avoided asking menopause questions because I didn't know how to treat it. And then I realized how much it was overlapping with my pelvic pain and how much I actually wanted to learn about it. And so I then sought to really learn about menopause from the standpoint of conferences that I was going to, training that I received as a menopause practitioner. And it has now become a huge part of my practice and something that I'm very passionate about. So that's kind of how I got to the menopause part of things. And at the same time, it's obviously exploding right now in the media and in general with various things that have happened, but women really taking it into their own to become advocates for this stage of life, which for so long has kind of been brushed aside, or people have been told to deal with it. I think one of the other things I would say is that in a lot of the patients I deal with, pelvic pain wise, there's a lot of gaslighting. These patients have come in being told nothing is wrong. And so the same thing has happened with menopause and perimenopause, where either they're just told to deal with it, or you're still having a period, you're fine. And women are really suffering. And so to be able to have the skills to help and educate women has become, that part of my practice has really become very important to me.
Yeah. Things like you're just getting older. This is the aging process.
Exactly.
Right.
Yeah.
Yeah, it's tough because, pain is such a universal thing. And the reality is there is some truth to the fact that as we get wiser in our years, I like to tell my patients that things do break down. We have a little bit wear and tear. There's some cumulative trauma. There is some damage. But oftentimes, there is something under the hood that can be looked at. And I think just as a word to use, gaslighting, I don't know where I heard this recently. So you have two things going against them, right? So one, women have been neglected in medicine with respect to research and the resources allocated towards studying the issues that are unique to them. And then also the aging population, seniors, that's another thing. And so they got the double whammy on that regard, right? You mentioned that. Give me a sense of what's the average age range of the person that you're dealing with? Because I know like what the folks that we work together with, like it could be as young as 16-year-old, 17 years old.
Yes.
And so
really, since we're talking it could go from endometriosis, and we're talking about could be starting in teenage years, in 18. And then from a menopausal standpoint, or women that are having things going on, I'm seeing people up into their 80s with sort of newer onset, not simple to treat, what we'll maybe get into later, genital urinary syndrome of menopause, but coming in with a lot of vaginal pain, urinary recurrent UTIs. And those are these, older women in their 70s or 80s that have been suffering for a long time. And there are also other skin conditions that can affect the vulva that tend to be something in older women. And a lot of people just, it's been itching, it's been burning, I've just been dealing with it. And then at some point they do get to me either through an annual or a referral. So I really see a whole age range. Certainly with this menopause population, it's, averages 40s to early 60s.
Yeah. You had mentioned something interesting, which hadn't occurred to me. You said that despite going through residency and a fellowship, you did not feel prepared to treat this population and this pathology, if I can even call it that in particular. What residency would prepare you? Is that an endocrinology thing that somebody would be more prepared to do that?
Well, I think that's part of the issue in general. And you'll see, at least on social media, with a lot of these, what they call sort of like menopause warriors, or this whole team of menopause practitioners that are talking about how actually so many providers need to be educated, because it does fall on OBGYNs, but it also is orthopedic in nature. It can be dermatologic, it can be cardiology, internal medicine, because there's 25 plus symptoms of menopause, perimenopause. But primarily, I mean, an OBGYN should absolutely, we're taking care of women or people with vulvas across the lifespan. That is something from a gynecology standpoint that's a huge thing we should be educated on. And because of all of the scare behind hormone replacement therapy, the WHI study, which I know we'll get into, it was really passed over. I had the one lecture I remember receiving in residency was from an attending. It was all based on the WHI data, and a lot of kind of scare tactics where people really weren't prescribing, or very few and far between. I didn't understand everything that happened in menopause. I had no idea of the different options of medications. It was very overwhelming when I did go out into practice and realize I had so many women coming to me just at their annual having various issues that were all consistent with menopause, and I was not sure how to help them. This is several years ago, and now I'm obviously much more equipped, but it took a lot of hours and a lot of colleagues and a lot of conferences to really get that training. And that's not a unique story amongst people who are now specializing in menopause in terms of how they gained that expertise, because it's not in our training. Hopefully more so now, but
the lost generation, as they've been named, these folks you're talking about. So let's get right into it, right? So you've used a couple of terms, right? We've talked about menopause, perimenopause, there's postmenopause. Can you clarify what each of those means? Maybe we could put some timelines on when expectations are. Of course, nobody's bodies don't read textbooks, I like to say. And so people are going to approach it different timelines, but give us a little highlight on that.
Yeah. So perimenopause, so menopause in general, I guess we'll start with menopause. That is the single point in time after a woman has stopped having a period for 12 months. And so that can only be sort of retrospectively understood. So then we go, and the average age of menopause is said to be, at least in the United States, 51 to 52. But then when you read worldwide, it's more like 48. But it ranges from late 40s to mid 50s that it's going on. Perimenopause is the time period leading up to that final menstrual period. And that is a time where women can have significant symptoms because there's a hormonal roller coaster of sorts. And that time period can be 10 years. So these are women showing up in their late 30s and in their 40s, still potentially having, well, not potentially, having menstrual periods regularly, or maybe starting to skip months here and there, but with significant symptoms. Postmenopause is really everything after that. I haven't had a period for 12 months.
Mm-hmm.
And, I think what's important to note is that women spend about 1/3 to 1/2 of their lives in this menopause time period. So it's a huge part of the lifespan that women are having this sort of different hormonal milieu.
Yeah. So you mentioned the WHI, right? So the Women's Health Initiative depends on who you follow, who you listen to, could be the greatest debacle in science.
Yeah.
The worst executed study, worstly conducted randomized control trial. Or if you talk to some people and say, well, actually, the study was quite good. It's the interpretation and the execution afterwards from the data. That is where the ball was dropped. What camp are you in, or where do you fall?
Yeah. It's interesting because sort of in preparation for talking to you, I reviewed the WHI and some of the other literature, and it's always been something. I feel like it's finally starting to become more clear to me, but it's very confusing because it depends who you read and what you think. So I think that the issue is the absolute misinterpretation of the data and the generalizations that were drawn about hormone replacement therapy based off of a population that is not the population that we actually treat. So I don't know if we want to get more into age.
Let's do it. Yeah, let's tell people exactly what the study was and how it is executed.
So the Women's Health Initiative was the largest double-blind randomized controlled trial that followed 161,000 people from about 40 different medical centers that the WHI started. The women were recruited between 1993 and 1998 with an average follow-up of about 5.2 years. So the WHI was aiming to look at estrogen only versus estrogen progesterone therapy, with the primary outcome being, is there any reduction in actually coronary heart disease? And that was non-fatal MI or just any coronary heart disease, with a secondary or a primary adverse outcome of invasive breast cancer. They were also looking at incidence of stroke, PE, uterine cancer, colorectal cancer, hip fracture, and death. The study was prematurely stopped in 2002 because the report came out that there was a very increased risk of breast cancer in the estrogen and progesterone arm. The estrogen arm did continue. So that is where and because that came out, basically hit all the headlines, and overnight about 80% of people who were getting hormone replacement therapy, it stopped. And so all of these women who were getting treatment stopped because it was now hormone replacement therapy, or now menopause hormonal therapy causes breast cancer. Retrospectively, there's been a lot of reinterpretation of the data. So, a couple of the things that happened is when they talked about this risk, they talked about it as a relative risk, as a percent change, rather than an absolute change. So they said there was a 26% increased risk of breast cancer, which would certainly make someone think, wow, I should stop. But then if you go into absolute numbers, that was an increase of 8 additional cases. So it went from 38 per 10,000 person years, from 30, not on estrogen and progesterone, to 38. So we're increasing 8 in 10,000, which is a rare event and can be similar comparatively to drinking an alcohol drink a day, being physically inactive, being overweight. So the way that it was written and interpreted, that was one of the problems. The other problem was that the placebo group who didn't receive anything, was actually, in looking back at it, it wasn't that the group taking HRT had a higher rate of breast cancer. In looking back at it, The placebo group actually had an unusually lower risk of breast cancer, potentially because many of them had been on hormones in the past. And so when those people who had the lower rate were removed from the comparison, there was no longer any difference in breast cancer rates between the hormone replacement group and the control group. And I've seen these nice graphs where that difference just disappears. So that's part of just the data that was not how it was interpreted incorrectly. Also, the average age of women in this study was 63 years, significantly older than who we recommend receiving hormone replacement therapy. And they said, the WHO said it was a relatively healthy population, but in fact, it was not a truly representative healthy population. There was actually 35% were overweight, 34% were obese, 50% were current or past cigarette smokers, and then you add on this median age of 63. So all of this, you cannot generalize these results to the entire population. So when there was a reanalysis of women aged 50 to 59, they ended up finding lower all-cause mortality, lower coronary artery disease, and no increased risk of breast cancer in this estrogen and progesterone arm, or in the estrogen-only arm. And then subsequently, the estrogen and progesterone arm, there have been, is it actually the type of progesterone that may have caused what was the slight increased risk? But in general, the WHO has walked back all of their claims, really with the exception of this breast cancer risk, depending on who you talk to. And that actual thought has just been pervasive amongst providers who still think hormone replacement therapy equals increased breast cancer risk, when we really know that is not the case.
Why haven't they walked back the breast cancer piece of it?
Well, I mean, there's an entire book about it. I think some of it is just who the principal investigators were, and specific one or two of the people who just won't, just kind of, I think they want the belief so much to be that breast cancer risk is increased that they sort of massage the data to the point that they just won't.
I got you.
Okay. And I mean, also the other thing that I would say that was brought to my attention just as another thing is that in the study, when they talk about this 26% increase, they say, quote, the 26% increase in breast cancer incidence among the HRT group compared with the placebo group almost reached nominal statistical significance, meaning it did not reach statistical significance and it could have been spurious. But as one of the PI people said, because breast cancer is so serious an event, we set the bar low to monitor for it. We pre-specified that the change in cancer rates did not have to be that large to warrant stopping the trial. The trial was stopped at the first clear indication of increased risk. This is one of the people who will not sort of backtread. So this is kind of the, sticking their head in the sand type thing. But as a result, many people suffered.
So what's really interesting is, I think, let's state this, right? So we're recording earlier in December. I think it was last month or the month before the FDA came out and just took off the black box warning of all of these. Was it last month in November?
Yeah, it was November 10th.
Yeah. Mm-hmm. So they had a whole press conference and everything like that. Now, I was a little too young. I guess back in 2002, you said they abruptly stopped it.
Yes.
My understanding is from listening and reading that they actually made a big deal out of it. They put a press conference. They were like, we have to stop this ultimately. Mm-hmm. You and I are not too far in age, I don't think. So you were probably a young girl as well at the time.
I don't remember it, not at all.
I'm curious, though, have you had conversations with other women in your life, maybe your mom, aunts, other relatives, and if they were on menopause hormonal therapy and at that point had stopped? Is this somebody that you've had conversations with people close to you?
I would say not so much close to me, because my mom was a situation where she was a breast cancer survivor. Not something that was ever offered to her. However, I have had patients who talked to me about their mother, for example, who was on it and was stopped, or patients coming in and they're very much being dissuaded by their mothers who were of that generation, who heard that news, who absolutely never touch it because of this breast cancer risk. But yeah, in terms of, it's definitely, I think a lot of the generation, like our parents, but I didn't have anyone close to me that was sort of had these medications removed suddenly overnight.
I'm wondering, if we can talk a little bit about the age and how that's relevant. So you had mentioned the average age in the United States around 51, 48, if we consider other parts of the world. The average age in the study was 63. What is the downside of actually starting MHT at somebody in their mid 60s? And because I'm even thinking about the people, that lost generation, so to speak, right? So maybe this is these women who maybe 10 years ago were hitting that 48 to 52, and now they're going to be in their early to mid, maybe even late 60s. My understanding is that estrogen has a particular role when those arteries are lined with some plaque versus not. Can you talk a little bit about that?
Yeah, so that was, part of the issue with that WHI study was the age, which was 63. And so what has been elucidated since that point in many studies is this sort of window of opportunity, the prime time for benefit from hormone replacement therapy, namely estrogen, which is prior to the age of 60 and within 10 years of menopause. And that is because in that time period, there is decrease in cardiovascular risk, increase in symptom relief, decrease in any adverse, specifically like heart attack, stroke, blood clot. Whereas over 10 years from menopause, greater than 60, you have higher baseline vascular disease in general, increase in atherosclerosis, and so increased risk of coronary heart disease and stroke when you add estrogen later. As although estrogen can have, like you were saying, protective effects early in menopause when the arteries are still elastic, they can improve endothelial function, be favorable for lipids. Once the plaque is established, could be many years after menopause, estrogen actually may destabilize those plaques and increase the risk of stroke. And so that's where that greater than 10 year, greater than 60. And then from a brain health standpoint, although estrogen earlier on may be neuroprotective and there's more and more work being done into that, late initiation may confer no benefit. And the WHI talked about an increased risk of dementia, which is also something that can very much be debated in terms of how they defined it. But those are sort of the reasons in terms of the stroke, coronary heart disease risk.
Yeah, I love it. Thank you for that. All right, so let's get into recognition. You had mentioned earlier on that 25 symptoms or so, maybe probably even more, right? But spanning multiple specialties. And one of the challenges in medicine is that, we practice in silos, right? So you're OB at this point, you're doing primarily GYN, pelvic, and you've got a little niche. I've got my thing here. I'm doing a lot of non-surgical musculoskeletal medicine, but really the body doesn't operate that way, right? Yeah. It doesn't recognize that I need to go see GYN, I need to go see him or sports guy, or I need to see somebody else. And so, you're going to have a disease process and you're going to have the symptoms that you're going to have, and the patients are going to have the complaints that they have. So what are some of the common things that practitioners should be able to recognize? Mm-hmm. And maybe we can just for simplicity bucket that into different areas. You had mentioned orthopedics as well. Mm-hmm. Where do you think it makes sense to start?
Well, I think talking about kind of the way that it does span a lot of different specialties, because there are the classic hot flashes, night sweats, mm-hmm. other symptoms of vaginal dryness and urinary symptoms, which are sort of more classically, I guess, recognized by GYN. But then there are significant cardiac type things where women will start to experience a lot of palpitations, heart racing. And so many people, once they come to me, they've already had a full workup with cardiology, worn a Holter monitor, done all the things, when really, if we sort of had talked to them about everything, we would say, actually, this is like perimenopause, menopause. Then we have a lot of people, there's inner ear itching is like a tremendous symptoms. Itching in general, like scalp itching, but the inner ear, it's just, will drive people crazy. And so many people have seen ENT for that and have been getting different treatments to try to figure that out. Then we have frozen shoulder and various musculoskeletal syndromes that happen in menopause, joint pain. People have had rheumatologic workups, and a lot of that increase in muscular and joint pain is also menopause related. So for me, I go through and kind of ask these 25 symptoms, and it doesn't have to be my specialty for someone to say, yeah, I have horrible joint pain. Like I can't, my knee, and for me to recognize that, not that I'm the only one that's going to solve it, because there's of course pathologies, but a lot of that, seeing these patterns and knowing these are entities that they fall into that category. And then I have a lot of referrals from psychiatrists as well, mental health providers, because there's a tremendous uptick in mood related issues, some really significant anxiety, new onset anxiety, panic, worsening depression. And so astute mental health practitioners are also realizing the time period in women's lives, and that some of that, instead of being put on an SSRI or some anti-anxiety medication, actually the women need hormonal medications, and that resolves a lot of the mood issues. So,
Yeah.
I mean, I don't know if that answers it, but it's such a wide array of symptoms.
The itching is interesting. I've never heard that before. Is that the mechanism? Is that the estrogen withdrawal? Is it progesterone? Is it both?
It's estrogen related. I mean, also like tinnitus is another one, dry eye. It's just and I don't know in the inner ear specifically, estrogen receptors and that sort of thing, but whatever it is, low levels of estrogen, also just dry skin. But itchy skin can be a really intense thing. And often, I mean, it's the inner ear thing and people have no idea. And then I say it and they're like, oh my God. And then the itching in the ears goes away once you start. But it is a low estrogen symptom.
Yeah. The orthopedic stuff. So it's the term has now actually been categorized as the MSM. So musculoskeletal syndrome menopause. And I first heard about this. I'm kind of ashamed that I didn't ever learn about this as somebody who prouds himself to really understand this system and pain in general. But it makes a lot of sense, right? And we don't learn about how, as you highlighted, the estrogen receptors are all over the body. So we have it in collagen, right? So estrogen stimulates collagen production. So as we're getting a little bit older, your tendons, your ligaments, they lose elasticity, become dry, brittle. Synovial fluid is another important one. So joints, as you brought up, and synovial fluid is going to bathe all of our joints. And over time, if you're going to get less of that, you're going to have less nourishment to that joint. And people have pain. Inflammation in general. Inflammation is just an interesting term because people will just throw that around without it really meaning anything. But from estrogen is a potent anti-inflammatory. So is progesterone. But when it leaves, inflammatory cytokines like TNF alpha are ramped up and they cause these systemic aches. So I think that's the mechanism for those who are interested and from those of my colleagues listening. And then the other thing is, I think I might have texted you about this where I have had conversations, all of us who treat chronic pain, for all of our patients, when they get pregnant, their pain gets better. And that's just the case. And I went down this rabbit hole deep down. I'm like, what is it? It has to be a role in progesterone because that's the primary one. It's really all of the hormones, progesterone earlier on, and then estrogen as well. And came to learn that progesterone has a little bit of a GABA-like effect. So it has that Valium effect, right? Aside from the anti-inflammatory stuff that we had talked about. And if you have like a muscle relaxer, nature's muscle relaxer, overall, everything is going to feel a little bit better and you're going to be a bit more relaxed. So it's interesting. I worked with a guy on the inpatient side who, I cover from time to time, and he has an outpatient practice and I put everybody on micronized progesterone.
Right. I was going to say, this is micronized progesterone. This is because of one of the metabolites, I think pregnenolone, that is the metabolite that has the GABA effects. And so that's the progesterone we use for hormone replacement therapy. And taken in the evening, it has that mild sedative effect, helps with sleep. And so, never knew that until I started doing hormone menopause therapy in terms of why that, because there's all sorts of other types of progesterone that doesn't happen for.
Yeah. And the other challenges, I think we were talking about the aging population, is you have so many people as they have these somewhat vague, they have multiple issues. And I don't know if this is a system-based issue where you have specialists and subspecialists. So today I had a patient come to me who I had referred this patient for knee pain to one of my colleagues and came back and told me that doctor just does the back. And this is an interventional spine, but also musculoskeletal trained doctor, but now they're only doing the back. And you have some of the older docs who will give a shit and say like, oh yeah, eventually somebody just only does the right shoulder and then the left shoulder, and like I take care of everything. And that's frustrating for patients because when somebody comes in and they have pain in their shoulder and their knee and stuff, and then all of a sudden you're like, oh, you got fibromyalgia.
Yes,
especially challenging for women. And again, that's kind of what I was thinking about as well. And so I want to caution though to myself, but also my colleagues is like, and maybe we'll come back at the end and make a steel man for the case for the opposite side, is like, there are, as you mentioned, true pathologies, right? So if there is true underlying arthritis, it might not be hormones. It might be something else. The challenge is when things are really, really superimposed. I guess my question for you would be, is how do you tease out, right? Like, how do you tease out when you need to refer to me for something like this versus when you're like, I really do think it's a hormone problem?
Yeah. Well, first of all, I would say, coming back to, you were saying you were embarrassed you didn't know about this musculoskeletal syndrome of menopause. That only got named in 2024. I mean, it's the orthopedist, Dr. Vonda Wright paper. So it's not, and yes, it's very common, but these things are known but now being named. I would say, so in terms of what I refer to you, so sometimes people they've already been to a rheumatologist, they've been worked up for something autoimmune in terms of what pains they're having. If it's specifically localized to a hip, a knee, a shoulder, so we know frozen shoulder happens more in menopausal patients, it doesn't mean that I'm going to give you hormones and all that's just going to go away. But, sometimes if it's this, like, I just wake up in the morning and everything hurts, or like I feel like I'm 80 years old all of a sudden. Sometimes it doesn't take that long to start hormone replacement therapy and see how things are going to feel. So it's 6 weeks. So I always see patients back usually around 3 months time. And depending, some of them, the joint pain is gone. I mean, they feel so good. All their symptoms are improved. But for people who certain things persist, or I have a sense that they should see someone to really get the back looked at or the hip, I know that the prevalence of that is going to be more so in this older population for all the reasons you've said, wear and tear, age, and then all the things that happen from a musculoskeletal standpoint with lower levels of estrogen. So I think it's kind of looking at the complete picture. And for me, I'd always rather have more of a team around and consult you and see what you think, because I don't want to be practicing in a silo. So I really want to understand all the other things that could be going on contributing to pain.
Yeah. And then hopefully those different specialists are actually communicating and say, hey, I actually don't think this is the primary reason.
Right.
I think your hunch on to do what it is, what you do. And you and I do this all the time. And that's kind of one of my favorite things is, hey, do you think it's this? And, we're kind of just playing with these ideas. Is this going on? Should they be seeing a third person? Should we be tagging somebody else? And it's collaborative, like I think it should be. Yeah. So I'll give us both a pat on the back on that one. Let's talk about different formulations, because I think this is also important, right? And so I think people need to understand, and there's this really awesome piece I read on The Guardian, which actually was a response to the FDA announcement. Actually, maybe can you just tell the listeners what the FDA announcement that I referenced earlier, what was it that it talked about? So, Senator Kennedy was on there, Marty McCary, who's the head of the FDA, came and talked about that. What was that all about, and why is that relevant here?
So essentially, as a result of this WHI study and this claim about increased risk of breast cancer, there were FDA black box warnings put on all hormone replacement therapy products, including vaginal estrogen, which we know doesn't cause breast cancer, basically alerting women in big letters to increase in risk of cardiovascular disease, breast cancer, probable dementia with estrogen-containing products. And so this has been a huge thing just in terms of and the fight by a lot of the people who are fighting for menopause, that this information, which is inaccurate and also much more nuanced, should be removed. So essentially, initially what was trying to be done was just to get the label off of the vaginal estrogen, because that is a local topical cream where it's completely bogus to think that, or not bogus, but we know that there's no increased risk of breast cancer with topical estrogen cream. The other, all these other scare tactics, is actually, harming some women who would be prescribed something, pick up this medication, see these huge warnings. Who's going to want to take something that's increasing their breast cancer risk or dementia risk or increase? And when many of those things have been disproven. So the label has now been revised, whereby that black box warning is being removed actually from all estrogen containing products. And there's now going to be age and timing recommendations about that, taken within 10 years, less than 60. And then my understanding that it will be up to the individual formulations to sort of talk about on their own product the risks. So oral versus a transdermal, but that sort of big warning that the FDA had done from this data that has now been, understood to not be the true data has now been removed. So it was a really big, for many, not that it's changing how any of us who practice menopause are practicing, but more so for the public and also for patients to feel safer about what's generally regarded as a very safe treatment.
Absolutely. And it makes your life easy, because now when you're having the conversation, they're open to the conversation. They don't have a barrier and a wall put up, like at least the patient's mom, if they're in the room with them. Yeah. You've talked about in the WHI, it was all oral, right? Everything was systemic. Both
it was estrogen. Oral, so they were using conjugated equine estrogen, which is not, that it is still a use, but we use what is now considered body identical or bioidentical, so estradiol. And then it was using the medroxyprogesterone, which is a different type of progesterone than the prometrium that we typically use now. As in sort of the revisiting of the study, some of the issue was thought potentially to be due to the formulation of progesterone. So prometrium, which is the micronized progesterone and is body identical, is the preferred progesterone to be used with menopause hormonal therapy due to its safety.
Yeah. And I want to make sure that everybody understands, because you've used the term bioidentical and people will hear this and micronized, and that's the same thing, right? Different ways, right? Correct.
So bioidentical was kind of used amongst really as like a marketing ploy when people were getting things like pellets. The medications that we have that are FDA approved are bioidentical, but because they're not, they are, the correct term is now body identical because it's the same
I love that
molecular property, but it's, not that's kind of what's being used. So I'm trying to say that as that's what the people.
Is that compounded or no?
It is not compounded. So
awesome.
the sort of all the big menopause bodies recommend against compounding.
Okay.
Because it's not regulated, and the FDA, we have these good, safe products, and the compounding ends up coming from pharmacies where the medications are, it's not, I mean, many of them could be totally fine, but you can't exactly, no one is kind of coming in and saying, this is exactly what this is, you're saying this is at this correct dose. And then pellet therapy is sort of its whole other thing that people are doing. And you shouldn't need to be paying an arm and a leg for something that insurance covers, is also my feeling.
Are there insurances that don't cover it?
Most insurance, I mean, there's some form of hormone replacement therapy that you can get covered either through insurance or through Cost Plus, that Mark Cuban's online pharmacy. There's a lot of basic hormone replacement therapy that's super affordable. So there are ways to do it if your insurance doesn't cover it, you don't have insurance. But the compounded and the pellets, none of that's covered by insurance. So people are paying hundreds of dollars for that when they could be using something that they could pay for with insurance.
Interesting. So I want to start local, and then maybe we'll come back to systemic with respect to dosing and formulations, right? So you've talked about the vaginal estrogen. Mm-hmm. Talk a little bit more about symptoms that the patients will experience and the signs where you're going to make that decision. And then are there any other roles for the local estrogen, or is the vaginal really the only one?
Well, so there are now more and more products, actually estrogen for the face. And those are all, there's nothing prescription at this time. These are all compounded because of the properties that we know that estrogen can do to the skin. So there's a lot of people using estrogen-based skin products. However, from a prescription standpoint, topical would be the vaginal estrogen cream. It also comes as a tablet, and there's also a ring that you can insert as well, but it's all doing the same thing. So it's treating something that in medical terms is called the genitourinary syndrome of menopause, which are a constellation of symptoms that happen with low levels of estrogen, that affect both the bladder and the vagina and the vulva. So patients can complain of vaginal burning, vulvar burning, irritation, itching, pain during any kind of intercourse or anything penetrative, a lot of urinary symptoms, frequent UTIs, urgency, frequency, waking up in the middle of the night. Sometimes these are the most bothersome symptoms, and they're so easily treated with topical estrogen in a cream. And there's actually evidence about it preventing UTIs. And we know in older women, UTIs can really be a cause of significant morbidity and mortality. So I often see a lot of people coming in, they've had recurrent UTIs, or we almost use it as like a preventive type thing because there's so many benefits and there's basically no one that can't take it. It's that safe in terms of its use and works really well.
How often do they have to apply it? You said primarily symptoms maybe at nighttime, but is it multiple days?
It's twice a week.
Oh, okay.
Wow. Application, which, if someone is using a patch from a hormone replacement standpoint, there are patches that are also changed twice weekly. There's some that are changed once weekly. But what I will advise is if you're using the patch, change it twice weekly and use your vaginal estrogen cream those same days that you change the patch.
Makes sense.
So to start, sometimes there's a teaching of sort of a loading dose where you do it every night or every other night for 2 weeks and then go to your maintenance twice weekly. The reason for that, again, is just kind of the teaching, like how we were taught, but also just to take effect more quickly. So that is sort of, I give that as a choice, but it's not a necessary thing.
Yeah. Do they have a topical ointment or a cream? Like I know for testosterone replacement therapy, they actually have a cream that sometimes women will use to rub in. Do they have anything like that for?
Yeah. So for menopause hormonal therapy, that include, there's an oral formulation, which is a pill that I was telling you about. Then there's a gel. So that's probably similar to the testosterone that you were talking about, that comes in doses and individual use packets. And so that's just rubbed onto the skin once a day. And then there's a spray as well that is sprayed onto the skin, and you can self-adjust from 1 to 3 sprays. And that's another route. And so those last 3 are considered transdermal or through the skin. And then the first one is the oral.
For the transdermal, is your preference the patch?
My preference is the patch because that is just what insurance ends up covering a lot of the time. And it's just it's nice and it's easy. You sort of put it on, set it and forget it type thing.
Yeah.
And it tends to be very well tolerated in terms of maintaining steady states. People tend to do really quite well on it. Some people like to do something every day and like the gel. Some people like the spray where they can self-adjust, especially if you're kind of doing a little something perimenopause related where you may need more in one part of the cycle than the other. You could do the first half of the cycle, or 2 sprays in the first half, one, kind of adjust it as needed what your symptoms are. But the patch is just, it's very nice and simple, and people know how to use it, and we can adjust dosing pretty easily, all of them. But that one is probably the one I most commonly prescribe. And then the pill would be the other thing that I prescribe.
I would think with the gel and maybe even the spray, there might be some concern that it could rub off onto kids if you have them, family, other people like that. Is that something you caution people about as well?
Yeah, so you're supposed to let it dry and not put anything else on it for an hour. And so for some people that can be prohibitive. I mean, the transference is going to be so minimal. The gel, they're alcohol based, so they dry really quite quickly, and like it's not transferring. But if that is a concern, I say, use it at night before you go to bed. And then, there is not going to be any issue with that.
Okay, awesome. When you're having the conversation for the patient, let's say they've seen the updated press conference by Marty McCary, and they're coming in, and you have a patient coming in, maybe they're 53 years old, they're complaining of some of these symptoms, maybe got some joint stuff, the GSM that you've talked about. And you say, hey, let's try this. What are the risks that you're still giving them some caution about, 10-year, 20-year? Talk to me through that conversation, what that looks like.
So I basically talk to them about the benefits of estrogen in terms of kind of what their symptoms are and why estrogen will help them. And then in terms of the formulations, it's really oral versus transdermal. And so when people have a certain history, so the oral, there may be a slightly increased risk of blood clot with the oral formulation because it's going through the liver and first pass metabolism. And so there was recently something I saw, a really great graphic sort of showing the relative rate of blood clots. So with estrogen tablet, it's very low. With a birth control pill, it's higher than what I'm talking about, but still very low. And with pregnancy, it's far higher. And women all the time and not worrying about blood clot, and everyone, many people pill. So from a relative standpoint, it's incredibly low. Like we can still give, but the reasons that we wouldn't do that would be, for example, someone who is a smoker. They can still get hormone replacement therapy, but we're going to want them to do the transdermal route because we don't want any kind of someone with migraine with aura. Those people, they can still get it, but because of that theoretical increased risk, those people can't take migraine with aura, can't take birth control pills because increased risk of stroke. So same thing, we're going to move them to the transdermal category. Maybe high cholesterol, any sort of risk factors for atherosclerotic disease or coronary heart disease. But for the most part, it's generally very safe. But if someone wants the absolute safest, where that risk of blood clot completely goes away to whatever one's baseline is, then that would be the transdermal option. So the patch, the gel, the spray. In terms of ability to tolerate, it's really it's all the same actual medication. It's getting metabolized slightly differently. And some people just tolerate one more than the other. Estrogen by mouth does metabolize into a couple of other types of estrogen in the body. So sometimes that, people do better with that versus through the skin. Some people have better, steadier states with the patch, for example. that's being changed every 3 days. So I really kind of give them the options. We tailor it to what someone wants. It's not a one size fits all. So sometimes we try a couple of different options or change doses. And then if a woman has a uterus, she does need to take that progesterone. The micronized progesterone is typically what I will start with because of the safety profile surrounding the micronized progesterone. And that is typically taken at night, and we can adjust that dose because there are increasing sleep and mood benefits if you increase the dose. Some people can have progesterone intolerance and not feel well, either with bloating, GI side effects, headaches, that sort of thing. And in that situation, we can certainly switch to another type of progesterone, be it what was used in the Women's Health Initiative, which is totally fine, another norethindrone. There's some other options that are still okay, like they're fine. But typically we'll start with something systemic, estrogen, progesterone if they have a uterus. And then if they're having GSM symptoms, often the systemic therapy can take care of that. But for many women, they do need an additional localized targeted approach to really get at that tissue. And so many people want that because it just can be a real game changer, because there's a lot of sexual function changes that happen. And so increasing blood flow and lubrication and getting that tissue healthier with the cream can really make a big difference for people and their comfort.
How often is the oral estrogen pill dosed? Is that daily or?
Mm-hmm.
Okay.
And they're all able to be dosed from a very low dose to sort of, whatever the highest dose is, which is frequently and almost always lower than what you would have in a birth control pill. So people think, in terms of understanding it, estrogen in a birth control pill, which we do use, and there's a role for in perimenopause, that's synthetic, and it does tend to be higher doses than these much lower doses that we're using in hormone replacement therapy. And I kind of explain it. A mentor of mine talked about kind of a gas tank being empty and sort of talking about estrogen. If you sort of are on, you're used to being at a quarter to a half a tank, and that's where you feel good. We're not trying to get you to 3/4 of a tank. We're trying to where you're on empty to like getting up to a quarter or a half, just so that the hot flashes go, like the symptoms get better. We're not trying to pump you with some crazy high dose of estrogen. That's not what's happening at all.
Yeah. I lost my train of thought there for a second. Give me a sense of numbers. Are we talking micrograms, milligrams? Like what's the starting dose for the transdermal and maybe even the oral just for the estrogen?
Yeah, so the oral is in milligrams.
Milligrams, okay.
The starting dose is usually 1 milligram.
Okay.
And then the patch dose is typically in micrograms. So 0.05 is usually the starting dose. And so because 0.05 micrograms in the patch is equivalent to 1 milligram for the pill.
Gotcha.
And then the spray and the gel are a little bit it's a little bit different in terms of that. But for most people, I will start them if they're coming in their 50s, sort of a standard fair person, either 1 milligram oral or 0.05 patch, unless they say I'd really like to start very low. So 0.025 is the lowest you can go with the patch. And the pill, you can also go to 0.5, which would be that equivalent. And those are also maybe lower doses. If someone is coming in their early 60s, they're still a candidate in many ways, but we're wanting to make sure, because they're sort of out of that window potentially, that we do the lowest dose for them, to get rid of symptoms. That would be a reason I wouldn't start them at the 0.05 per se.
And what about the micronized progesterone? What's
micronized progesterone is in milligrams. So the standard dose for uterine protection is 100 milligrams daily. It doesn't come any lower than 100 unless you get it compounded. And then if you do choose to take it in a cyclic fashion, which would be 12 to 14 days of the month, that is 200 milligrams you would take for 12 to 14 days of the month. Many women do end up just taking 200 milligrams or even sometimes 300 milligrams daily because it can help a lot with mood and sleep. And sometimes if there is any kind of breakthrough bleeding from the hormone therapy itself, the progesterone helps to stabilize the lining. So we may increase it in that regard. But 100 is the dose. It's
the floor.
200. Mm-hmm.
So I'm thinking about women in perimenopause. So somebody, maybe they have last menstrual cycle was 6 or 7 months ago, but they're having a lot of the symptoms that we're talking about. I would think that if we started HRT on them, we would probably send them into menopause, right? Because their body would, much like else, stop producing that from that negative feedback system. How do you think through that? How do you talk through that with them as, okay, we're going to do this and then you're going to do this indefinitely? Because we probably can't stop
So actually, if we are putting someone on hormones and they're perimenopausal, we are not going to be putting them into menopause.
Okay.
So really, if you are perimenopausal, presumably you're still cycling, your ovaries are getting quieter, but you're still making estrogen, you're still making progesterone, maybe not at the levels that you were, but you're having symptoms. And so what we're doing in that regard is basically adding to what your body is already making, that sort of gas tank thing. So if you're like used to being at a half a tank and now you're sort of always at a quarter of a tank because of perimenopause, we're just kind of boosting you up. So your cycles are still happening, whereby like versus birth control pill, that those doses are high enough that basically kind of takes over. Your ovary is not kind of ovulating and doing its thing. Those hormones are doing the thing. So it's really it's like additive. So women will still continue to bleed regularly or have their irregular bleeding. So one of the big things in perimenopause can be heavier periods, erratic bleeding. And so hormone replacement therapy isn't great for treatment of that because it's not really doing much with the bleeding. So that's where sometimes we talk about other things like an IUD. So sometimes, we will start it and have to adjust doses because there are such fluctuating levels of hormones in perimenopause, which could be more difficult to treat. You're not like at a low, you're sort of high to low, but some of the idea is you're kind of reducing those high to low swings. And some of that can be part of the mood related symptoms. So they will often still, I do many perimenopausal patients who are still getting regular periods or they're weird, every 3 or 4 months and they're on hormone replacement therapy.
So it sounds like the dose is low enough where the negative feedback to the pituitary is not going to shut it off.
Correct.
Endogenous production.
Right.
Gotcha.
Exactly.
Cool.
Yeah.
I want to come back to the breast cancer piece for a second. I think one of the things that we have actually a lot of clarity on is the fact that, if you have certain genes, if you have some predisposition in your family, particularly the BRCA mutations, your personal risk of breast cancer is very, very high. And so how do you have the discussion with the patient who have a very strong, robust family history of breast cancer? Maybe they've got some BRCA carriers in there. And for those who don't know this, BRCA is the gene, and any type of mutation into that increases your risk of breast cancer. I don't know exactly by what percentage. Maybe you can tell us about that. But how are you having that conversation with those patients?
Yeah. So I think that some of the sort of misconception around breast cancer and hormone replacement therapy is that if you have a strong family history, that you're not a candidate for it. And so that is not true. So people who come in and may have a strong family history, it doesn't mean that they're not candidates for hormone replacement. It's not going to increase the risk above what someone's risk is for the most part. However, if someone has a pretty significant history of breast cancer in their family and ovarian cancer, I would potentially talk to them about it making sense to potentially get tested for some sort of genetic mutation, because then that might be something that a BRCA carrier might want to do something about, whether it is an oophorectomy, removal of the ovaries, whether it's a prophylactic mastectomy, genetic counseling, potentially talking about medications that can help. But it's not something that if you have BRCA in the absence of any kind of breast cancer, you still can take hormone replacement therapy. So many people would say, no, you can't, but there's nothing in the actual guidelines that says that you are not able to. If you have a personal history of breast cancer, that is something that we tend to not. But even so, there are many circumstances from a quality of life standpoint and working together with an oncologist where that may end up being the most beneficial thing for a woman to do. And it's a really gray area in terms of will it or will it not increase any risk? But quality of life standpoint, many people, if they're that miserable and other things have failed, they may say, I want that. But for genetic carriers, that is, something that is not, you can still have that. And there's something that I don't think I have it. I might have to look, but I think if you are BRCA positive and you have an oophorectomy, you have your ovaries removed, and you take hormone replacement therapy, you actually have a lower risk of breast cancer. So there's things that are kind of almost a little bit counterintuitive that, again, in my learning of this entire world, there's a lot of data and there's a lot of stuff and misconceptions. So, excuse me if I'm sort of still not talking out of turn, but there's certain data that I more recently have been learning where I was like, oh, okay, that's an interesting one. So it's not like it's off the table for those patients. But
Yeah.
genetics can be something that is very important for one to know for themselves in management as well as for their family.
No, I mean, no, I appreciated it. The fact that you're so informed is somewhat impressive to me. I mean, as you talked about, I think that, I'd use the term lost generation, but I also think the physicians in our generation, we just weren't taught. And people will talk a lot about this as, this, like you said, what year did you graduate from residency training?
2018.
Yeah. So you're a couple of years ahead of me. And, I think that probably our attendings at that time was like, no, this is what the status is. And we're not going to discuss this, as you talked about. Not to mention, you're doing the OB and GYN, two specialties in one. And, that's a different conversation for a different day, probably. But I want to talk about when menopausal hormone therapy would not be the right thing. So we've highlighted a couple of cases, right? So you talked about a patient with migraines with aura where that might be contraindicated. Other patients, maybe a relative contraindication, not an absolute contraindication, but where would other strategies be more impactful? I'm actually thinking about this, and I don't know if this was mismanaged, but when my mom started menopause and stuff, and she was started an SSRI actually, and that was probably because she had some of those symptoms where were mood related, some of the hot flashes and stuff. And interestingly, I was uninformed at that time, and now we're going to have a different conversation for sure. But I'm thinking about what other approaches you can take to manage some of these symptoms, because that's the thing that's most obtrusive to somebody's quality of life.
So I would say one thing to correct, and I might have misspoke. So migraines with aura is not a contraindication to hormone replacement therapy. We would not do oral.
That's right.
Formulation. Patch would be fine. Migraine with aura, we don't like to do with people with birth control pill because of that.
That's right. You did say that. That's my bad.
No, it's fine. Just wanted to make sure that. So in terms of like absolutes for contraindication for hormone replacement therapy, we had someone with history of a heart attack, any history of blood clot, be it a DVT, blood clot in the leg, or a PE. If it's provoked, that's a different story, and often you can do transdermal for them. But DVT or PE, unexplained vaginal bleeding, like you need to get that, we have to figure that out before we start you on something. History of breast cancer. There are, of course, nuances for many of those, but those are kind of the things where the risk is, in many cases, outweighs that benefit. So in terms of other options, so your mom may have been started on an SSRI. She may have been started on Paxil or paroxetine, because that is an FDA-approved non-hormonal treatment for hot flashes in women. So Paxil is one of them. We also off-label will use Effexor, which is another antidepressant. Gabapentin is another medication that can help with hot flashes. And something when I was reviewing things this weekend, I think I read gabapentin and Paxil will help in about 60% of people from a hot flash standpoint. So when it works, it's great if they can't take something hormonal. There is a newer non-hormonal medicine called Veozah or Filuzanant, I think is how you say it. I might have said that wrong. That's within the last couple of years. That's a non-hormonal treatment for hot flashes. That is sort of like, it may work, it may not. One of the side effects listed is hot flashes, which is kind of crazy. So you have, those options for hot flashes. In terms of the vaginal or the genital urinary symptoms, you can really almost always do the vaginal estrogen. There's some other types of formulations. We might use something called DHEA, can be placed vaginally. Sometimes for the mood, anxiety, for those symptoms, you may want or need an SSRI or some kind of antidepressant or anti-anxiety med if you can't take hormones or if there's an additional issue. And then, there are various things that we can do for sexual dysfunction as well, medications, but some of those, they're for premenopausal women. So some of this can be a little bit challenging territory. And we really do this like biopsychosocial model, really kind of addressing all the different parts of the equation.
I want to pull in that thread a little bit more. So as you know, the name of the podcast is Medicine Redefined. And I think the things in medicine that we didn't do a good job getting education on, certainly not our generation, is the role of exercise, the role of the importance of sleep. How does nutrition play into that? And so is that something that's part of the equation when you're having the conversation? I know, at least my reading of MSM, and you brought up Dr. Von der Wright, she is a very strong advocate for the importance of resistance training, right? And we've talked about this at length multiple times, that's exercise is medicine. You have to dose it accordingly. And so when we're talking about building those muscles around the joints to take the stress off the joints to improve their pain. We're talking about building those tendons and ligaments and loading them properly. That's a conversation I'm having with every single person that walks into, I shouldn't say almost every single person, but tell me a little bit about what that looks like for you.
Yeah. So I think that component, with perimenopause and menopause, some of the things that are most upsetting to patients are lack of sleep or interrupted sleep, weight gain, and then, inability to sort of lose weight or too much pain such that they can't exercise. And so really the talk is about kind of, okay, when we improve sleep, it's going to improve so many other things for you in terms of like from a metabolic standpoint, from an energy standpoint, from a hot flat, all of these things. And then also helping to be able to get some of the muscle and joint pain to be improved, whether that is with medication, but exercise and weight-bearing exercise, I do talk about a lot. The barrier for many people is that either they've gained a lot of weight and it's really uncomfortable, it hurts them, they are so exhausted, they don't have the energy to do that. And so kind of getting them to be in a better mood and energy place and kind of like back to the basics in terms of let's get your sleep better, then many women are able to start walking again. And, the whole strength training, that really has taken off. And I'm a big proponent of that myself and the importance of it. So I do try to talk about the importance of that because there are certain, programs targeted towards menopausal women that can be really helpful in that transition and kind of understanding that it's not necessarily about looking so muscular, but being, having that strength and the stability to support your bones and to have strong muscles. Some of these providers, Mary Claire Haber is a big menopause person. She has a lot of supplements that she talks about and a particular diet. I'm not as sort of in on those supplements. I think it's totally fine. Creatine is a big thing that's happening right now. I feel like I haven't done enough research to sort of say yay or nay.
We just had a podcast come out on it. You should listen to it.
I'll have to listen to it. Yeah. Because I love that sort of, very holistic approach. I'm not just, needing to give you only medicine. I think there's so many things that go into it. And so I'm definitely big on that as well.
Yeah, love that. Yeah, I'll have to check out that name sounds familiar to me. I think I've heard her talk, at least on Diary of CEO, but I need to check out the supplements. As you're talking about sleep, I was thinking about what we had spoken earlier about the micronized progesterone. I apologize if I already asked this, but is there ever a role for just the progesterone in isolation? Tell me about that.
So that often, because perimenopause can be difficult to treat, especially because people are still having periods or, it's just a little bit harder with these hormonal fluctuations. Sometimes some of the big things going on are mood, sleep interruption, anxiety. And so it can be really nice especially if you're kind of like, all right, let's start with something. Birth control pill is absolutely something that can be very helpful in certain circumstances, but many people can't or don't want to take that. So the Prometrium taken at night can be very helpful because it may help with some hot flashes, or night sweats, not tremendously so, but more so to get people sleeping again. Also with the progesterone and how that can affect mood, those levels, if you're not ovulating regularly, you're not producing those levels of progesterone, kind of bumping that up, especially even second half of the cycle when you might be feeling worse, that can be very helpful from a mood standpoint. So we can kind of experiment with doing it every night or just doing it for half of the cycle. But sometimes that can be a really nice sort of entree into starting and seeing how that feels. Yeah.
I just realized that we didn't talk about testosterone. And I think we've talked about this before, at least on this show, that even though we spend a lot of time, and when we think about women, we're thinking about estrogen, progesterone as the main hormones, testosterone is actually the most abundant hormone in the body and with respect to absolute metrics. And so what can you tell us about the role of testosterone? Is there a role in supplementation and replacement in this case? Why is that important here?
Yeah. I prescribe testosterone with some regularity. I think there's a lot of debate right now about testosterone. There's some, people in the menopause community who are very pro testosterone because the indication for it right now, the paper written, the dosing is about low libido in postmenopausal women. Okay. And so that, as one of the other main complaints people come in with, it's that, their libido has totally tanked. There's, and they're very upset it's affecting them, their relationship, their sense of self. So sometimes that is about getting, the estrogen is also very important, but testosterone can be sort of a icing on the cake type thing. Often once we kind of get hormones, the sort of estrogen, progesterone in a good place, people are still having pretty significant low libido issues, testosterone can be very helpful to add. And there is a role for that. We sort of have to, since there is no, in this country, prescription dose for women, we basically use the same medication that men are taking, and the little gel that I will have women use, man would use one full tube a day, and a woman is going to use 1/10 of that, so a little pea-sized amount that she'll rub on her her thigh or her butt, something like that, once a day. And we do check testosterone levels and liver function and monitor, and for some people it makes a tremendous difference. And then the other thing that it can help with, it does tend to, you see differences in cognition and brain fog. There can be some, increase in muscle mass and strength and mood. So just the same things it helps with men, there are people talking about these other benefits for testosterone. However, right now, the indication for it is low libido in postmenopausal women. Do I also use it in perimenopausal women? Yes, because I'm also using hormone replacement therapy in them, and they're suffering from some of those same things. I think, there will be more and more, I guess, with testosterone coming up, especially as people are being more vocal proponents of it. So I think that there's a role for it for sure.
What's the average time that you'll give just the estrogen and progesterone building block, so to speak, to get that dialed in, and you're like, okay, I feel like we're in a good place. Now is the time to add testosterone? Months, years, what are we talking?
Yeah, I usually say about 3 months, because I have patients start whatever dose that we've just decided they're going to start on, get in touch with me in 6 weeks to kind of let me know how they're feeling. We adjust that dose, and then usually they come back at 3 months. And if we make any other dose adjustments, I really want to make sure we're good on that, because often libido gets better. The vaginal estrogen can do a lot from the standpoint of sensation and lubrication and help with, from sort of that standpoint. At that point, 3-ish months, once we're stabilized, that is when many people are coming to ask me because they're seeing it talked about and written about, but sometimes I will offer that up. For some people, it works amazingly. For some people, it doesn't work, and so that's the case sort of with everything, but I want their hot flashes. I want everything else optimized, because so many other things in terms of low libido, it's not in isolation. It's so many things, sleep and, a ton of different parts that go into sort of how your mind is thinking about and wanting sex. So I'm not making them wait and wait, but I do want to do the other sort of more traditional things that I am excited about using testosterone. I've been using it for the last several years on patients.
I'm interested in monitoring. You brought that up. It's primarily symptom based, right? These symptoms that we're treating, it's all symptom based. It's how they're feeling. It's a purely clinical diagnosis in that sense. Whereas opposed to TRT, testosterone replacement therapy, when somebody comes in, they'll have those symptoms and maybe some of the signs that you had talked about. We will get baseline levels. We'll check twice. We'll make sure they have to have a level that would be suggesting, they would have hypogonadism. We could talk about why that's happening, and then we'll potentially treat it. And I will recheck in about 6 weeks, 8 weeks. Of course, the most important thing is, how are you feeling? Mm-hmm. Those things that we had talked about, are we making improvements? And then to the thing that you had talked about with a gas tank, I really love that analogy. Like, we want to get that person back to kind of where they've always been. Ideally, if we've had levels and we know that between 400 and 600 kind of nanograms per deciliter, if they've done well, we want to get them back to that. We don't want to get that person up to 1,000. That's not going to be helpful. Is that the case in terms of monitoring? Something you'll look at, you'll make the diagnosis that this person is, having these symptoms of menopause. And do you check a baseline and then check afterwards?
Yeah. So I will. So in terms of this, and again, this is all stuff that I've kind of been learning by colleagues and reading papers, because no one in my practice is doing it, maybe a little bit through me, but the guideline at least is to check a baseline, to also check liver function. It's, what we're looking at is total testosterone, but depending on who you listen to, some people are also checking free testosterone. Some people are also then doing a sex hormone binding globulin to then calculate the amount of available testosterone. I think what I've kind of come to is that it seems like total testosterone is what I should be looking at. And then, the range really is trying to get it like 40 to 70 potentially. So people who are coming to me that have had pellet therapy, they are frequently in having testosterone levels in the 100s, 200s, such large clitoris, they have lost hair, they maybe have voice changes. That is not a safe way to do testosterone. That's not what I'm trying to do. Those people may have incredibly high libido, but they feel terrible. They feel ragey. They don't like the way they feel, and their hair is falling out and they have hair growth in other areas. So I'm monitoring, and I usually don't like, even if someone has sort of a normal testosterone level, who am I to say that that was always their normal? So it's more about kind of what is their baseline and making sure that they're absorbing it, that we don't need to change that, or I don't have to say, hey, instead of making a tube last 10 days, let's make it last 7 because your levels are still pretty low. And then, yeah, I will usually monitor it 6 weeks, and then usually I do 3 months and then 6 months, and then kind of like.
What about the estrogen and progesterone? You're checking that too?
So there's actually not any indication for checking estrogen or progesterone. So estrogen, like in all of the guidelines, you treat based off of symptoms. So I know if you're coming in and you're menopausal, your estrogen levels are going to be less than 50. Like I just know that I don't need to do any lab work. Your progesterone levels are going to be very low. If you're in perimenopause, it's going to mean even less to me because you may be going back and forth between an estrogen of 50 all the way up to 500. So it's not going to tell me anything, but there are specific instances where you are checking, for example, if you're increasing the estrogen dose and someone is not responding, because there are what are called poor responders, via estrogen in a patch formulation. So maybe you have to change from a patch to a pill. So to kind of see what levels there are. And then there are certain menopause practitioners who are doing more boutique medicine who do say that there are certain levels for bone health and bone protection, like 40 to 70, for example, for estrogen levels. So they may be checking based off of the fact that they're trying to make sure a person has adequate levels for bone protection. That's sort of a little bit out of the guidelines. In a most standard way, I'm not checking because it's not telling me anything. It's really, are your symptoms better? Something is weird or someone's not responding the way that I think they should, we may check. And sometimes if someone is, for example, has had a hysterectomy, so we don't know whether they've been a year without a period, again, I can treat them regardless of what their levels are, but some women do like to know, like, I want my hormone levels checked. And if that's something that is important to them, I'll say it's not going to make a difference in what I'm doing, but we can certainly do that. And it may be conclusive for menopause, or it may be like, yeah, looks like you're in perimenopause, but it doesn't matter. I'll treat you the same.
Makes sense. I think before we close, I think it's important for us to play devil's advocate and look at the other side. As you've mentioned, I think you called them menopause warriors. Yeah. There are a lot out there, and there's no shortage of people who will, bash the WHI, and for valid reasons. Like you highlighted a lot of the flaws in the study. Although I did listen to a really great podcast. It was the Dr. Mike podcast. I don't know if you know him, The Checkup, and he had Dr. Jen Gunther on there, and she had talked about some of the things with the WHI study. For instance, like people will say the horse urine, right? The estrogen derived from that. It's like, I don't know this to be true, and I haven't actually looked at it. She said at that point, that was the most commonly used, right, formulation that people had. And so they used the information they had, and they try to do the best of it. It's the interpretation where I think the ball was really dropped. But this piece that was really interesting, I'll send it to you, and I want to kind of read a little excerpt to you where Dr. Marty Makary, so this piece is in The Guardian. Marty Makary says, there may be no other medication in the modern era that can improve the health outcomes of women on a population level than hormone replacement therapy. And he calls it life-changing, even life-saving treatment. Senator Kennedy had said hormone therapy was extending the lives for women as much as 10 years. And then, another person here says, today we have the opportunity to add up to a decade of healthy years to the life of every woman that you love. Alicia Jackson here. And the reality is, a lot of the, I guess not the proponents, the opponents of this will say, well, actually, we don't have a lot of great evidence that it reduces all-cause mortality, all the things, by as much as what they're saying. Certainly not a decade. We don't have the data to say that.
Right.
As we've touched on time and time again, this is a symptom-based thing. And I mean, listen, both of us, I think the primary thing that we do, we're trying to improve the quality of life thing. That's pretty much all my job. I'm not doing anything life-saving in my job. And so it's not to dismiss that's not important, but to make these bold claims that it's going to add a year or 10 years of your life, I think that can be really problematic. But we're talking about headlines, right? That's what catches headlines. Right. And you've talked about these boutique clinics, these people. And I think my suspicion is, in fact, more than suspicion, I can almost wager that a lot of these telehealth clinics, this menopause industrial complex is going to pop up more and more. These TRT clinics, peptide clinics are popping up even more. Hormones can be really tricky. And so I guess what I want to learn from you a little bit, see where your head's at in terms of where do you see this explosion of telehealth menopause platforms and what concerns you about it, if anything?
Yeah. So, well, first thing I would say in terms of that, what you were reading is that I think some of like the nuance in there is the fact that estrogen and hormone replacement therapy can reduce risk of cardiovascular disease, and heart disease is like the leading killer of women. And so some sort of menopausal hormonal therapy may, reduce risk of those sorts of deaths up to 50%. So prevention of osteoporosis, and we know that hip fractures are a huge reason for mortality. So estrogen preventing hip fractures is also, you have to be on it for a longer period of time. That's also another way that people may improve their lifespan. But I think, making these very broad claims, it is sort of some misinformation. It's like the pendulum is sort of swinging in the other way. I think there are a tremendous number of benefits from hormone replacement therapy. But yes, those numbers of 10 years, we don't have those numbers. We do know that there are many benefits. I would say from like the telemedicine standpoint, I mean, to be, very transparent, I do work for a telemedicine company called Alloy, and they practice all evidence-based medicine, and they're doing, menopause medicine, skincare, sexual health. They just added on some weight management. So I think that, and it is the practitioners, I think they're now up to 27 physicians. And these are all people who are menopause certified. These are some of the top people like in the field that, are some of my colleagues that I get to ask questions to. And I at least see from what we're prescribing, because we're only prescribing FDA approved type things, the patch, the pill, the gel, Paxil, versus some of these others, which may be doing things like progesterone in a cream form, which we know it doesn't really get absorbed well, and that may not be enough, or things that don't have enough evidence yet, like DHEA. So I think the issue is that there is a need, there's a market because people are reading this stuff. And then there are a lot of deserts in the country where people do not have access to someone who they can go face to face with and give them their care and give them good information. And so that's why I think many people are turning to these telehealth type situations. So I think the onus is also on providers to become educated and to be able to provide that to their patients, so patients aren't needing to, one, pay a lot out of pocket where they may have insurance that could cover it, and two, find someone locally who might be able to help them. I think everything you have to kind of look at with caution, and what are the products, who's prescribing them. And so that's why, I was very discriminating in working for this company in terms of I highly respect what they're doing, how they're doing it, the patients they're helping, and the message, which is all evidence-based. There's nothing that's being done that isn't outside of the exact guidelines that I follow in my office.
Yeah. Is estrogen, progesterone controlled?
Estrogen is not controlled. Many people, progesterone is not either, just testosterone. So many people are coming onto these platforms asking for testosterone, and that is not something that Alloy provides. It's a controlled substance. It, for a variety of reasons, it's not FDA approved yet. So that, I'm not sure. I don't know of any other companies where people are able to get testosterone, but I mean, obviously lots of people can get it compounded, but you can get what you want from somewhere, but it's about safety. So,
so coming back to some of those warriors, right? So I'm not going to pick on Gwyneth Paltrow. Everybody picks on her. So let's, I think I had read about Halle Berry. I remember Mel Robinson listening to her podcast, talking about her brain fog and cognitive symptoms. And I think she's a lawyer, having been so sharp for a majority of her life, and then now all of a sudden struggling to do some basic things for her. And I'm just wondering, do you think generally that is a helpful part of the conversation for folks such as yourself who are trying to do this, quote unquote, in an evidence-based fashion, who are trying to add nuance to the conversation rather than just say, study is all bad, everybody needs this, this is going to fix all your symptoms? Where do you land on that?
Well, I think the brain fog, those sorts of cognitive changes are very real and very distressing. And you have these like high functioning people who start to not be able to find words and can't remember things. And they think, many people in menopause think that they have Alzheimer's, like it becomes that scary. And a lot of that stuff and the attention, inattention, sort of some ADHD symptoms, a lot of that can improve with hormone replacement therapy because we know estrogen affects the brain, and there's more and more studies being done on the cognitive benefits and potentially prevention of dementia. I mean, they're not things that are being said super loudly, but those are part of, use and some prevention. So I think that at least some of when I say menopause warriors, I'm sort of talking about actual like medical providers that are passionate about this, getting out there on social media, disseminating, information. Everybody has their own sort of, I'm big on testosterone, I'm big on vaginal estrogen, whatever the thing is. But I lost my train of thought. Oh, I think that the thing that's important, and I heard one physician talk about this, is that when she has patients coming to her, she's not ever saying, I'm going to make you feel 100% better, but she's aiming to get 70 to 80% improvement. And so I think that sort of expectation setting for, it's not just sort of a magic, everything's going to be better. But I will say that I have people come in and they're just like, I feel so much better. I feel like myself again. I can't believe I felt this bad for this long. So it can be just absolutely an incredible thing for certain people that are really suffering. But, not everything is appropriate for everyone, and not everything will always work exactly the same. And so I think there's, being able to understand the nuance and figure out if things aren't working, what else to do or other places to look. But, there will be frequently there's improvement, not someone's going to feel like they're 25, but we can get people to feel, often a lot better if they're appropriate candidates.
Do you see any over treatment, or do you have any concerns about inappropriate MHT use here at all? Or do you think is it that we're still catching up?
I'm not sure if I can really speak to much more than I guess myself per se. I mean, in terms of inappropriateness, I think it's the lack of use. So people who are coming to me who have gone to 2 or 3 gynecologists, or their gynecologist they've seen forever has been dismissive. So it's kind of that lack of understanding this part of the life cycle and how to help a person and what are the very real symptoms going on. I would say some of the treatment that I feel can sometimes be slightly dangerous or negative would be some of the pellets, because I do feel like people are getting very high levels of testosterone. Also, not the way that it works, these sort of having these pellets put in, having these peaks, ebbs and flows of their hormone levels. So they feel great, and then they start having hot flashes again, and just not being sort of educated on the evidence, what the options are. So that's where I see it being like, that really makes me upset. Sort of there's this market of people, the vulnerable people who need help, and that's the only place that they go. But by and large, I feel like, I've had, maybe someone who is doing their very best as a primary care provider and may start something, then I see the patient and I think, it might not be the safest thing to do for X, Y, and Z reason, but might I have done that 5 years ago? I mean, yeah, I was not good menopause provider before I learned all this. So it is a learning process. And I think you have to develop the people around you to help learn how to prescribe and ask the right questions, because there is so much nuance to it and a lot of misinformation that has gotten propagated over the course of these last 25 years.
For sure. And our hope is conversations like this helps people get educated. I think I don't know where I heard this, but the reality is that no person is not going to be untouched by the struggles of menopause, right? If you're a woman, you're going to probably experience it at some point. Definitely experience it at some point. If you're a male, you probably have a woman in their life who is going to experience it at some point. Mm-hmm. I mentioned I've already done that. And, my wife at some point, I'm sure is going to go through this. So it's good to be armed with knowledge and pick this up earlier on so you can intervene for better quality of life, which is probably the most important thing, at least to us, that we care about.
Absolutely.
Lauren, if you could, like I said, just the underuse is what you highlighted, maybe the inappropriate use, right? So over the next 5 years, if you could change 2 or 3 things in our healthcare system with approach to menopause, what would they be?
So I think it would be more specialties armed to prescribe hormone replacement therapy. So you were asking whose job is it? And I think that making it so that it's not doesn't just fall on the gynecologist, but that there's someone can go see their primary care doctor and that person might recognize it, prescribe it, or an endocrinologist or a urologist, or even, a psychiatrist, which sometimes they will. So kind of having a wider swath of people that have the knowledge and the understanding, because it's also not rocket science to prescribe it once you sort of, do it enough, and you can do the low risk and then kind of build up your confidence. So that would be one thing, is just a wider breadth of people taking care of menopause. I would say, what else would I want to say? More training. So more training at the residency level. And I think the only way to really get people like internal medicine doctors and other primary care, people to know about is to actually learn about it, because it, like you said, it will affect every single person. So it's going to be something that many people, residents in training, are going to come across someone who's having, some of what's going on is their menopause related symptoms. So I think widening that education from a residency training standpoint, actually some sort of a curriculum, or even starting in medical school. I mean, I don't remember learning barely anything about menopause in medical school. This is a huge, lack. Like, that's a huge thing that's missing from our medical school education. And then I would say, I think right now I'm finding that there's a particular who, I think she's Italian. Her name is, what's her name? Lisa Mosconi. And she's doing some really amazing research looking at brains and hormone replacement therapy and the role of estrogen. And so I'm really looking forward to sort of the information that comes out as it relates to cognition and brain health and dementia as it relates to estrogen and or estrogen deficiency, because I think, at least since I've heard her talk, she's doing some really interesting work.
I love it. Amazing. Lauren, is there anything that you think that we didn't cover that is worth talking about?
Man, I think we got through. I had some notes here. I think we got through so much.
Good. I'm glad.
Yeah.
And I know that we didn't even get too much into the Spivack special, but hopefully you're going to join us in a future where we can talk about another important thing, something that you and I have closely been working on over the last couple of years together.
Absolutely.
So the last question that we like to ask everybody, we practice in this system in the States where it's getting people better after they've already endured something, an illness, a sick care system, we say. And so what we're interested in is practicing healthcare. And so the question is, how do we put the health back in healthcare?
And from a menopause standpoint, almost?
Wherever you want to go.
Well, I think that, at least from my standpoint, I am catching women often in time periods, for example, like their annual, where nothing is actually wrong. They are not sick with anything. That's part of what I really like about gynecology and obstetrics. It wasn't always about, an illness, but that is actually a time where I've been taking the opportunity to talk about things like, you're at an age where perimenopause might be happening, where menopause is starting. I want to just talk to you about some of the things that may be starting to happen so that you will become aware of them, or even bringing someone back just to educate more. And I'm really big on giving people books to read, different people that are reputable on social media, just the tools to really be empowered and understand their own bodies, to then be able to make the decisions before a thing happens that they're then dealing with 3, 6 months, 3 years, 5 years down the line. So I think, it's a lot about, for me, the education and validating. And that's what I would have to say. Yeah.
Yeah. I'm just thinking, I don't really have any preventative annual visits. Patients they don't come to me for that. Yeah.
So
they come to me with problems.
Right. So that's where I have that. And even, menopause, they're coming in, but then it may be an opportunity to talk about, some people at that point say, I'm 55. Like, I don't really want to have sex anymore. They just normalize various things.
Yeah.
And that's really the opportunity as someone who's interested in sexual medicine or pelvic pain to say, you don't have to feel that way. We can talk about this. And I think just opening that door up and having a safe space and talking about, like you said, as opposed to sort of the sickness part of it, and what kinds of things that we can continue to expect from a health standpoint, and, is what's important with my patients.
I love it. Lauren, thank you so much.
Thank you so much. It was great to chat.
Likewise. Till next time.
Okay.
Thanks for listening to another episode of Medicine Redefined. If you enjoyed this episode, please be sure to check out some of the additional resources in the show notes.
Please also check out our social media platforms where you can find more content like this. You can follow us on Instagram, Twitter, and TikTok at Redefined. We also want to thank our team for the production of this podcast, specifically Ethan Ju on video, Harita Yepuri on social media, Zainab Lugmani on research, and Sarah Khan for newsletter. Oh, and if you want to get similar bite-sized information delivered to your inbox every Sunday, please be sure to sign up for our newsletter. Also, if you enjoy the show, please be sure to subscribe, review, and share with anyone who you think will gain value from this as well. Now, time for the ever so important disclaimers. This podcast is intended for general public use and is for educational purposes only. It does not constitute the practice of medicine, nor should be construed as medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues.